Is making a decision to go on treatment sufficient to ensure that the patient remains on therapy? I think all of you that hear this segment would obviously immediately say, no, it's not. It is very important to openly discuss with the patient adherence to medication, burdens regarding the medications that the patient is on in terms of side effects, fiscal burdens, can they get the medication, has their insurance changed, how is the copay affecting them? So to explore all the barriers that actually lead to reduced adherence and compliance with the medication. One of the very important considerations around most of the medications that we have available is the fact that once with ongoing therapy, compliance goes below about 80%, the disease activity of multiple sclerosis returns to its natural history course for that particular patient. Since we all want to afford the patient the best possible outcome from treatment and from management of multiple sclerosis, consideration of adherence, appropriate questioning of adherence is a very important part of follow-up visits with the practitioner. So how can one potentially ensure that the patient is actually adherent to medication? Obviously, this is only possible if the patient actually gets the medication. And so very often, many of us get the letters from the pharmacy benefit provider indicating that the patient hasn't refilled medication. If one has a question in a given patient, there is also a possibility to get from the pharmacy benefit provider a printout or a readout of the patient's refill history. Important, this is an integral part of the considerations that we have during every follow-up visit. Are you taking your medication? How many doses have you missed? If you have missed doses, why did you miss them? What was the problem surrounding it? Is it a burden that you don't want to take the medication? Do you have side effects? Could you not refill the medication because you had copay issues associated with it? Have you changed your insurance plan and the old medication is no longer covered? All of these are very important points, and there are the different approaches from the EHR, from the electronic health records, to the pharmacy benefit records, but the patient history in itself is also very important. Obviously, this is slightly different for medications that are administered at an infusion center or for medications that are administered at very infrequent courses of treatment. It is important to, when we have a patient in front of us and we consider a potential MS relapse, one of the cardinal points to first do is to ensure that the patient doesn't have a pseudo relapse. And when I use the word pseudo, I don't mean that this doesn't look, feel, or has the characteristic of a relapse for the patient, but it's more a recrudescence, a return of prior symptoms that the patient has experienced because of an infection. Very often when patients go to the emergency room, the first thing that is done is they are given a dose of steroids. Very often there is no urinary tract infection rule out done, so not even a UA is done. Where in patients with a new activity, it is very important to ensure that the symptoms are in fact new by history and that the symptoms are not due to an infection. Subsequently, if the patient has true new symptoms, it is also indicated to image the appropriate part of the central nervous system where the lesion is suspected, because showing new lesions, particularly in patients on treatment, will A, have a conversation or open a conversation with the patient regarding adherence to current therapy, and B, if adherence is present, also a discussion with the patient regarding switch of medication to an alternate mode of action. Multiple sclerosis is a lifelong illness. It requires to see the patient at regular intervals, to get to know them. It is important to understand where they stand in their disease process. With that, it's also important to understand how the patient is at baseline in their neurologic functioning. This will allow us to evaluate the patient when they present with changes in their neurologic functioning. This makes it easier for us. It is also important to encourage patients that if they incur new symptoms, to contact the practice so that we can see them earlier. Because again, if a patient had symptoms that started 3 or 4 weeks ago and they are already under plateau, it may be less helpful to consider treatment for an acute relapse in this particular patient. As always, when a patient presents with new symptoms, it's important to ensure that we are treating a true new event and that we are not just treating the side effects of an infection. It is important to keep in mind that multiple sclerosis patients go through periods of relative quiescence followed by periods of more disease activity. It is important to monitor also the patients that appears clinically stable for subclinical progression of their disease. It is helpful if in a practice certain standard measures can be performed, such as the 25-foot walk that could be integrated into the vital signs, such as the 9-hole peg test, and perhaps the single-digit modality test, to have a formal assessment of every patient with a quantitative measure that can be followed over time. If a patient comes in and has a clear change in their 25-foot walk, this may lead to a completely different flow of that care visit. If the patient comes in and has on a Snellen chart a clearly changed vision, this will affect how we look at this patient's stability. If the patient would have a significant decrement in the single-digit modality test, this also will lead to discussion with these patients. It will be important as we look forward to value-based care to integrate measures that are quantitative rather than just qualitative evaluation of the patient with multiple sclerosis.